So I'm here representing a large consortium, the A-WOL consortium, and I'll just give an overview of the developments and advances in the portfolio of new drug discoveries. I think it's important at this point to point out that Mark Taylor, who's in the audience here, is the person who actually instigated this, but early on in the development of this Bill and Melinda Gates funded initiative, it became clear that drug discovery was going to play a big part. So he brought me in specifically to try and help with that drug discovery portfolio. So I just want to put that into context in terms of Liverpool as an organisation, or Liverpool School as an organisation that's committed to drug discovery. And this is something that we've been involved with now for over 20 years. And just to highlight the commitment of the organisation, we recently, well, 6 years ago now, set up this £26 million specific institution to develop and discover and develop new insecticides, new drugs, and new diagnostics. And it really is quite an advance for us in terms of the facilities it gives us. So we have 22 Category 3 containment areas, including facilities for high-throughput screening, for imaging, and for FACS and single-cell sorting, which is quite unique, I think, in the UK. We have dedicated medicinal chemistry, maybe 30 or so FTEs at any one point, and we have a fully accredited GLP analytical lab allowing us to do GLP pharmacokinetics, which underpins most of the work that we do. Historically, most of our focus has been on malaria, so these are the portfolio of activities we've been involved in the last 20 years. We've been involved in the registration of 2 drugs, a further 2 into clinical trials, and several drugs up to the first into man interface. And more recently, we've branched out into tuberculosis and NTDs, which is the area that we're going to focus on today. So the school has quite a long history and experience in trying to drive drug discovery programs. So just to focus on the focus of this particular presentation is the idea of safe macrofilaricides for filariasis. The diseases that we're interested in are these 2 here, onchocerciasis and lymphatic filariasis. They blight the lives of millions, and the community believes that these both should and can be eliminated. And the strategy to date, has been to use annual or biannual rounds of MDA with drugs that stop transmission rather than kill adults. It's a very flaky strategy because it doesn't kill adults, and it could take decades to deliver its end game. So there is a need for an alternative. Basic biology work carried out by Mark Taylor and others in the field have shown that the parasites that cause these particular diseases, these nematodes, contain an endosymbiont rickettsial-type bacteria called Wolbachia, and it has some very interesting features. So the Wolbachia is essential for larval development, for embryogenesis, and for adult worm survival. Interestingly, nematodes that contain Wolbachia, adult nematodes that contain Wolbachia, tend to have a very long life cycle, so they persist for 5 to 15 years. And this is the reason why these long rounds of MDA are required. If you remove the Wolbachia from those parasites, they die in a very benign way over 1 to 2 years. So it's essential for some feature of parasite survival. What's more, because they die slowly, you don't get the inherent toxicities associated with directly attacking the nematode. So it's quite a clean, innocuous kill. So again, this is why we think this is a paradigm-shifting strategy for these particular diseases. The other benefit of this type of strategy is that co-endemicity with lower is a contraindication in the current MDA programs. Lower does not have Wolbachia, so drugs that target Wolbachia have no impact on lower. So it's a clean kill in that co-endemicity environment. Significant amounts of clinical work carried out by Mark and by Achim Horov in the University of Bonn and colleagues in Ghana and Cameroon have definitively shown proof of concept that using a simple antibiotic, doxycycline, for 4 to 6 weeks, you can clear Wolbachia and kill these adult worms. It has the potential to rapidly accelerate these elimination programs if it's deployed in the correct way. The main caveat to that is that it's considered that the current strategies with tetracyclines are not appropriate because of the prolonged treatment regimen and also because of contraindications in pregnancy and in children. And this is just a section of a parasite showing these rickettsial-type Wolbachia inside them. And this very simple slide from a trial that Mark did in 2005 is quite elegantly displays all the key features. So these are microfilarial counts after treatment with doxycycline. They drop, but that's just natural attrition. They're not being killed. But importantly, in the absence of Wolbachia, these cannot transmit through the vector. And if you look at these patients 12 to 24 months after a full dose of doxycycline, 80 to 90% of those adults are dead. So this is one of many studies now which has confirmed this particular observation. So A-WOL was set up specifically, or one part of A-WOL was set up specifically to find alternative treatments for Wolbachia, which were compatible with MDA. That's been now shifted in the last 12 months to be a test and treat, but initially we were set out to try and develop MDA strategies. We were set a target of a treatment for 7 days or less. That was considered to be programmatically acceptable. And we wanted something that was safe in pregnancy in children. So the people who do drug discovery will realise building that into your preclinical program is an impossibility. But we certainly couldn't develop something that could be obviously contraindicated in pregnancy or children from the preclinical approach. One of the big challenges in this field when I first came into it is that we had a myriad of screens with strange and varied outputs, and nobody really knew whether they translated to the human condition. So the team, the A-WOL team, spent a lot of time working with the various models to try and develop a development cascade that translated to man. And what we simplified it down to in the end was an insect cell line containing Wolbachia that we could use for screening activities in vitro. We could then test. We didn't need to do any ex vivo worm activities. We could go straight into a immunocompromised mice with a human Brugia malayi parasite and look for larval activity in a relatively short readout of about a month. And if that was successful, then we can move into an adult Brugia model. It takes longer to read out, but gives you a definitive answer as to whether or not you're killing Wolbachia in the definitive parasite target. And then ultimately into man. In the background here, obviously, there's lots of medicinal chemistry, there's PK/PD, there's lots of other things going on to complement these particular decision-making processes. So I just want to go through, the thing I should have mentioned at the beginning, almost everything we've done both before A-WOL and in A-WOL has actually been done in partnership. And in terms of the activities I'm now about to present, we've had very, very successful collaborations and partnerships with all of these organisations on here. So pharma, large and small, have all shown great commitment to this particular initiative. In terms of the screening, obviously the starting point for drug discovery is new chemical entities through a hit identification process. We've gone through a various stages of screening development, which is ended in a partnership with AstraZeneca, where we moved from a very, very low throughput quantitative PCR readout to this very high throughput imaging readout. I won't go through the actual assay, but AstraZeneca believe this is the most complicated whole cell screen they've ever had to validate. And Rachel sat in the back, in the middle here. I'm sure if anyone wants to know what the complications were, she'll spend an hour to explain them to you over coffee or over lunch. But essentially what we've been able to do as part of the program is we've now screened over 2.2 novel chemical entities for anti-Wolbachia activity. We have more than 20,000 hits. 6,000 of those have gone into full dose response curves, and we have about 1,000 or so which have sub-micromolar IC50s as our starting points. These have been clustered using standard strategies, and they are a prioritized list identified, and we're systematically doing lead optimization through those particular priorities. And the strategy we've taken, this is just an example which we've actually deprioritized because of a metabolic liability, is we're looking for structures which show multiple hits within a database. Here we had 7 compounds which had potency in the screen. In these radar plots, we established whether they have drug-like Lipinski-type qualities, and you can see they all do. From a chemical point of view, we're looking from a med-chem strategy for sites where we could relatively easily bring in variability and look for SAR. And then we carry out some basic underlying biology, activity, some physicochemical characteristics, and metabolic stability and binding to try and identify where the liabilities are. Remember, we're trying to develop a 7-day treatment, so the 2 key points of that is high potency and high stability in vivo. And in the context of this particular drug, we were unhappy with the activity, and we were unhappy with the metabolic stability. We could crack this, we could get this down to single-digit nanomolar activity, but we could never solve the metabolic instability, which is a P450 liability at this point here. So that's just an example of the way in which we go through that lead optimization program. But we have identified our first candidate. This was a macrolide type compound that went into a screen. It's measuring worm length, but it's a surrogate for Wolbachia load, so you get a similar graph with the Wolbachia load. We show our doxycycline having a significant effect. The macrolide hit, which came out of that screen when put in vivo, could actually deliver a doxycycline type effect in 7 days, but when we give it orally, the activity was almost completely lost. So the main liability with this hit was one of oral bioavailability, and it's because it's very polar macrolide, which had problems getting across membranes. And this is just the PK data that confirmed it. So this is IP administration and oral administration of the hit. That's subsequently gone into a medicinal chemistry program in partnership with AbbVie. A second and third generation of this macrolide have been generated, and this is one of 2 molecules which are going forward for preclinical evaluation. And you can see here, this is our cutoff. So anything that produces a Wolbachia load greater than this is better than doxycycline, and if you get the pharmacokinetics right, should be better in vivo in humans. And you can see here that 7 days at 50 milligrams per kilogram, 14 or at 50, or 14 at 25, this particular macrolide is superior to doxycycline. We're progressing this as 2 flavors, and this is just some of the summary preclinical data for one of those flavors. This is safety predicted based on AUC, safety based on Cmax. This is what we expect to need to actually deliver a 7-day or better cure in these 2 diseases. And this is the point where we're starting to see some loss of tolerability in preclinical screens. So this particular macrolide, if everything holds up, has a safety window so far of in excess of 100-fold. So we are confident that we have something that will do what it says on the tin in terms of kill Wolbachia, and we also feel that we have a margin of safety which should allow it to go through the development process, and this is something we're working on with people at DNDi. We've also looked at repurposing molecules as part of our program. This is one example of those. So in the early stage processes, we looked at a number of known antibiotics and other drugs in the pharmacopoeia. Something that came through that was quite potent in those studies is rifampicin. And this is the data from one of our in vivo experiments here. And you can see compared to doxycycline, rifampicin is significantly superior, and minocycline, another tetracycline, which we'd also shown to be better than doxycycline. This particular, on a mass-for-mass basis, rifampicin is significantly superior. So we've been able to show that 50 milligrams per kilogram of rifampicin in our models should be projected to achieve the TPP in a 7-day treatment in humans, because, of course, we have human data on pharmacokinetics, and we also have a trial where we underdosed rifampicin in these patients, and we got a suboptimal effect, but we did get an effect on Wolbachia and on the parasites. So this is where we were when we started in 2008. This was the portfolio of activity for anti-Wolbachia compounds. We had doxycycline, which was a proof-of-concept molecule, which several clinical trials had proven delivered what we wanted. And this is where we are now. So in terms of hits, over 2 million compounds screened, thousands of credible drug-like chemotypes, and dozens of leads. These are just some of the leads which are in the process of being optimized in Liverpool, in China, and in Africa. We have 2 candidates. We have the macrolide I discussed, and there's another repurposing molecule, which again predicts a 7 or less than 7-day treatment from a human tolerable dose. But there's some bridging studies that we need to do before we can reveal what that repurposing molecule is. Proof of concept drugs, we now know that we can deliver an anti-Wolbachia effect with rifapentine and rifampicin, with moxifloxacin, and also with minocycline. Okay? The ones that are likely to show a benefit over doxycycline are the rifampicins. And we have doxycycline, which actually can be deployed now. So we've actually moved doxycycline from a 200 milligram per day 6-day treatment down to a 100 milligram per day 4-week treatment for both LF and for onco. And this is the dosage that people usually take for those sorts of periods for malaria prophylaxis. As I say, this work involved a cast of thousands. I'd just like to mention Mark Taylor and Paul O'Neill, who does the chemistry. But all of these organisations have helped drive this portfolio and are still in partnership with us. And we are reasonably confident that over the next year or two, we should get to a point where we can push at least one of our candidates into a clinical programme, and hopefully that will then lead on to something which can give us a 7-day or less treatment for these particular parasites. Thank you.